Welcome to the show. Today, we're bringing you a deep dive that's, well, it's going to fundamentally change the way you think about one of the most common medical procedures out there.
It really is a massive paradigm shift.
Yeah. We are diving into a truly fascinating accepted manuscript from the July 2025 American Journal of Radiology. The paper is titled Opportunistic Screening on Chest CT. And we're just thrilled to have you joining us as we explore what this actually means for the future of your health.
It's a remarkable piece of literature. It takes something the medical community often views as entirely routine and completely reframes it as a massive, largely untapped resource for preventive medicine.
Right, and to set the stage for you, let's just look at a staggering statistic right out of the gate from this source. Back in 2016, there were an estimated 12.7 million chest CT scans performed in the U.S.
Just a sheer mountain of data.
Exactly, and that number is only growing, especially with the uptake in targeted lung cancer screening programs.
I mean, think about the volume of imaging that represents. You have millions of people sliding through that scanning donut every single year, generating terabytes of high-resolution anatomical data.
And think about why you usually end up in one of those machines in the first place. Maybe you have a persistent cough that won't go away, or a suspected lung nodule.
Trauma.
Right. You slip on the ice, you fall hard, and the ER docs put you in there to check for a broken rib.
Which is standard.
The standard. The radiologist checks for that one specific issue, they give you the all clear for the rib, and you go home. But the mission of our deep dive today is to explore how that exact same routine chest scan is actually a hidden gold mine of data for your overall health.
Yeah.
It captures so much more than just the one thing your doctor was actively looking for.
If we connect this to the bigger picture, this is the core concept of opportunistic screening. It's the practice of leveraging absolutely all the data captured in a scan, well beyond the primary clinical reason you were put in the machine to begin with.
Because you're already in there.
Exactly. The radiation has already been used, the images have been captured, and they're just sitting on a server. Opportunistic screening is about systematically analyzing those existing images for early disease risks. We're talking about everything from the arteries in your heart to the density of your bones, all just hiding in plain sight on a scan of your chest.
Okay, let's unpack this, starting with the heart.
The heart is a great place to start.
The source notes that coronary artery calcification, or CAC, is a major predictor of cardiovascular events. Basically, this is the burden of calcified plaque sitting inside your coronary arteries.
It's arguably one of the most robust predictors of heart disease we currently have. And historically, measuring this calcium required a very specific, dedicated type of scan. Radiologists would use an ECG-gated CT scan.
Gated meaning the scanner is synchronized with your heartbeat, right?
Precisely. It essentially freezes the motion of the heart to get a perfectly clear picture. Think of it like trying to photograph a race car speeding by. You need a very fast shutter speed synchronized to the car to avoid a blurry photo. Once they had that perfectly still image, they would calculate what is known as an Agatston score.
Right, by looking for pixels on the scan that hit a certain density threshold. The paper says anything greater than 130 Hounsfield units, or HU.
Yes. Hounsfield units are just the standard scale radiologists use to measure density, where water is 0 and air is -1,000. Bright white spots of dense calcium light up vividly at that 130 threshold.
But the shift here is that we don't necessarily need that specialized heartbeat synchronized scan anymore. The paper notes we can opportunistically spot this on non-gated routine chest CTs.
The exact kind you get for a bad cough.
Right.
A radiologist can visually assess the extent of the calcification even with a little bit of motion blur. The pooled correlation between the gated and non-gated scans is incredibly high.
And the so what here for you listening is huge. Studies show that discovering a CAC score opportunistically actually changes behavior. It leads to increased risk awareness and an increase in statin prescriptions.
It moves us from a reactive model to a proactive one. Discovering this by accident can literally save your life.
Okay, transitioning to the lungs. Detecting emphysema is standard practice, but you introduced me to this mind-blowing concept from the paper, airway dysynapsis.
Airway dysynapsis. It is a truly fascinating anatomical phenomenon. It's an anatomical mismatch between the airway caliber, the bronchial tubes carrying air, and your total lung volume.
To visualize that, it's like having a massive V8 engine in a muscle car, but you're forcing it to intake all its oxygen through a tiny cocktail straw.
That is a perfect analogy. That severe structural bottleneck is what dysynapsis does to your respiratory system.
Wow.
And the aha moment here is that this mismatch is established way back during lung development in childhood.
But it affects you decades later.
Yes, it independently predicts your susceptibility to COPD as an adult.
So if a doctor sees that mismatch on a scan of a 30-year-old who happens to smoke,
They can sit them down and explain that their lungs are anatomically wired to be highly susceptible to COPD. Catching this on a scan could trigger early, aggressive smoking cessation interventions long before irreversible disease sets in.
it makes the risk personal. It's not just smoking is bad, it's smoking is uniquely dangerous for your specific anatomy.
Exactly. Custom data is much harder for a patient to ignore.
So we've covered the heart and lungs, but we need to talk about body fat. Because BMI is the standard metric everyone uses, but the paper points out it's deeply flawed. It completely fails to differentiate between muscle and fat.
BMI is a very blunt instrument. Two people can have the exact same BMI but completely different mortality risks based on where their fat is actually distributed. A chest CT bypasses the scale entirely and reveals exactly where the fat is hiding.
And the paper breaks this down into specific compartments.
Yes, starting with subcutaneous adipose tissue, or SAT. That's the fat just under your skin. Then moving deeper, you have intrathoracic adipose tissue, or ITAD. Fat sitting inside the chest cavity itself.
Which can actually physically press on the lungs, right?
Precisely. It decreases lung function simply due to mechanical effects.
Yeah.
Then we have intermuscular adipose tissue, or IMAT.
Fat infiltrating the muscle.
Right, which is highly associated with metabolic syndrome.
Yeah.
But that brings us to the most critical fat compartment visible on the scan.
Here's where it gets really interesting. Epicardial adipose tissue, or ET. Fat located specifically between the myocardium, the heart muscle, and the epicardium.
It is fat that is physically hugging your heart, and it has a pronounced paracrine effect on the heart itself, meaning it secretes chemicals and inflammatory markers that directly bathe the heart tissue.
And the paper highlighted a study from Japan on this that just blew me away. Researchers looked at patients hospitalized for COVID-19 to see what predicted the severity of the disease.
And it wasn't BMI.
Yep.
The study showed that ET volume, that specific fat actively wrapping the heart, was the best potential predictor of COVID-19 severity.
Not their overall weight, but the fat around the heart. It just proves that a CT scan is magnitudes more valuable than stepping on a scale.
Which naturally leads us to the other side of body composition, our skeletal muscles and our bones.
Let's shift to muscle. When we think of muscle health, we usually think about size, the skeletal muscle area, or SMA. But the paper emphasizes that a chest CT shows us the internal quality of the muscle.
This is a crucial distinction when talking about sarcopenia, the progressive loss of muscle mass. It's not just about the muscle shrinking. It's about a process called myosteatosis.
The fatty infiltration of muscle.
Right. As fat infiltrates the tissue, it lowers the muscle's overall density on the scan, measured as skeletal muscle radioattenuation, or SMRA. You can literally see the muscle quality degrading.
Almost like the marbling you'd see in a steak.
Exactly like that. And this degradation independently predicts worse survival outcomes.
The COPD gene study mentioned in the paper was a huge aha moment regarding this. For smokers, the size of their pectoralis muscle, the PMA, is a massive indicator.
The longitudinal data was striking. If a smoker lost pectoralis muscle mass over time, their mortality risk jumped significantly.
And this was independent of their BMI.
Completely independent. Even if their weight stayed the same, the internal loss of that specific chest muscle signaled a massive decline in health.
So the scan is quietly tracking your muscle age, but it's also tracking the foundation of your skeleton. Usually, people get a specialized DXA scan for osteoporosis.
Which remains the clinical gold standard. However, an opportunistic chest CT perfectly captures the T1 through T12 vertebrae in your spine.
Right down the middle of your back.
Radiologists can take their software and drop a region of interest, an ROI circle, right into the spongy trabecular bone of the T12 or L1 vertebra.
They just measure the density inside that tiny circle.
Yes, they measure the Hounsfield units, and if the density drops below 100 HU, the doctor knows immediately to recommend a formal DXA scan.
It's a completely free, highly accurate early warning system for osteoporosis.
Before a life-altering fracture ever occurs. Preventative medicine at its finest.
So hearing all this, the heart calcium, the lung mismatches, the toxic fat, the marbled muscle, the thinning bones, the obvious question is, why isn't this happening every single day? If I get a chest CT tomorrow, Why isn't my doctor handing me a comprehensive report on all these biomarkers?
Because manual measurement would completely destroy a radiologist's workflow. The sheer volume of data is overwhelming.
Enter artificial intelligence.
Exactly. There are now FDA-cleared AI tools software like CNA, Briefcase, AVW, and ClearRead,
They just run silently in the background.
acting as an automated triage system. They automatically segment the lungs, measure the calcium, find hidden rib fractures, all while the human radiologist focuses on the primary issue you came in for.
It sounds like the perfect solution, but the paper points out a major technical catch.
This raises an important question regarding the physics of the scans themselves, the harmonization problem.
The technical hurdles. You can't just compare a scan from a hospital in New York perfectly to a clinic in London.
Right, because a CT scan is a highly complex physical measurement based on radiation attenuation. And those mathematical measurements can be radically altered by how the scan is acquired. The manufacturer, the slice thickness, the software filters.
The examples in the paper really highlight how delicate this math is. Like, if they use IV contrast dye, that actually artificially increases the bone density readings of your spine.
Or if the technician simply changes the tube voltage on the scanner, the diagnostic threshold for osteoporosis can shift by up to 62 Hounsfield units.
Which is massive, especially since the cutoff for recommending a DXA scan is exactly 100 HU. A 62-unit shift is a huge margin of error.
It could easily lead to a misdiagnosis or cause unnecessary panic. This is exactly why harmonization is the grand challenge right now. We desperately need standardized reference values tailored to age, sex, and race.
Just like the MESA study did for heart calcium, they tracked over 6,000 participants to create specific reference values so you can see exactly what percentile your score falls into. We need that exact same level of harmonized baseline data for muscle, epicardial fat, and bone density across all scanner types.
Until we have those correctly calibrated reference values and AI that can correct for variables like tube voltage on the fly, the data is interesting, but not universally actionable.
So what does this all mean? Let's bring this home for you. The next time you or a loved one gets a routine chest CT, whether for a persistent winter cough or after an accident, remember that it's no longer just a narrow snapshot of a single problem. Because of the convergence of advanced medical imaging and AI, that one scan is actually a comprehensive blueprint of your physical future. It contains the map of your cardiovascular risk, your metabolic health, your muscle age, and your skeletal strength.
And that leaves us with a profound final thought to consider. If AI can now automatically extract this incredible wealth of preventative health data from a single CT scan, what hidden patterns of human aging, disease, and longevity are currently locked away, just waiting to be discovered in the millions of archived CT scans sitting in hospital servers from the past decade?
Oh.
Could the cure, or the early warning sign for your future illness, already be sitting quietly on a hard drive from a scan you had 5 years ago?
That is an incredible thought to leave on. Thank you so much for joining us on this deep dive into the hidden data of your own body, and we will catch you next time.